But this is a sort of, I'm going to try and give you an overview of the way that I see ALL. Okay, so what I'm going to do in this talk is try and give you an overview of ALL and just talk to you about how patients present and the diagnosis and the principles guiding treatment currently. And I'm going to really focus on adult ALL because I'm not a pediatrician, I don't take care of children. And I'm going to talk quite a bit about prognosis and predictive factors in ALL because determining the risk for an individual patient is quite critical in figuring out what the right treatment is and whether somebody should have a bone marrow transplant or not. And that clearly has an enormous impact on someone's entire life. So a little bit about how we eventually would choose a treatment strategy for an individual patient. And then I will just talk about sort of likely direction for some of the future therapies that have recently been approved in for patients with relapsed ALL, and to kind of comment a little bit on how they work and how they might be incorporated into treatment strategies in the future. Can I have the next slide, please, Zach? So some of this might be really clear to everybody, but I always think it's better to start from basics. So I'm sure any of you experts who have actually had this disease or had family members who've had this disease know pretty much what's normally meant to be in the blood. As you can see here, there are a range of normal cells which are meant to be in the blood, and they all perform really vital functions. And we have a very standard way of looking at those. So we just draw a blood count and it goes through a machine, and we get an automated count of what the normal cells are in the blood. And we can also perform a blood film where the blood is smeared onto a slide, and we can actually visualize what the cells look like. And this is kind of a nice example because it shows pretty much one of each of the normal cells. So for example, you can see a neutrophil there, a lymphocyte, etc., etc. And can I have the next slide, please, Zach? And obviously, when you have ALL, something goes awry with that in a very significant way. So ALL arises in the bone marrow and eventually ends up with all of those normal cells in the blood, which I've surrounded by brackets here, essentially being overtaken. So can you just advance, because I've got some graphics here. So that's a picture of an ALL cell. So ALL cells arise somewhere around the level of the stem cells, which are in the bone marrow and form all of our blood, and the dedication of those stem cells to becoming lymphocytes. So they're somewhere on the spectrum of becoming a lymphoid cell, but fairly early, and almost at the level of stem cells in some cases. And as I'm sure you all know, those cells can either become T cells or B cells, but when they're interrupted in their development, they can become T-ALL or B-ALL. And can you just advance again, Zach? And what you essentially have is you have these abnormal cells which essentially take over the bone marrow and the peripheral blood, and which ablates essentially the normal function of the bone marrow and the blood. Can I have the next slide, please, Zach? And so the common symptoms which patients have when they present with ALL usually relate to either a lack of normal blood cells or general symptoms relating to accumulation of abnormal cells. So patients often will feel tired or fatigued and have shortness of breath, which often relates to not having enough red cells, recurrent infection to too few normal white cells, bruising or bleeding to too few platelets, and general kind of constitutional symptoms like fever, sweats, big lymph nodes, bony pain, due to too many abnormal cells in the wrong place, essentially, so in the blood, and then they can begin to accumulate in your lymph nodes, liver and spleen and so forth. And sometimes patients have no symptoms. So on occasion, I've seen ALL, be diagnosed upon routine testing for something else. And that's particularly devastating when that happens, because I think it's very hard for people to grasp the enormity of what's happened if they haven't had any symptoms. Many people don't have symptoms for terribly long. before they are diagnosed. So it's an acute disease, as I'm sure you know, and the vast majority of people are generally unwell for approximately 4 to 6 weeks before they finally receive a diagnosis. Can I have the next slide, please, Zach? And as I'm sure you're all aware, anybody who's been involved in this is the diagnosis can be made using peripheral blood, but we more often take some bone marrow, and we can, and that's a picture of that happening. I'm sure many people in the audience will be very familiar with this. And we can analyze the bone marrow, you know, in a number of different ways, which I'll tell you about in a moment. But what's critical about ALL, and also certain other blood cancers like AML, is it allows us access to a lot of material. So unlike a solid tumor, something like pancreatic cancer, where it's actually difficult to make the diagnosis, it's easy to make the diagnosis of ALL, and it's easy to get your hands on a lot of cells. And that's quite important in terms of research, because it means we often have a lot of leftover material from routine diagnosis, and can help us to do some very exciting things, which can then advance our understanding of the disease. So it's easy to extract DNA and RNA from these cells and to actually freeze down the cells themselves. So when patients are involved in trials, normally we would try and gain consent to do that and make sure we store material from every marrow, so that you're not only getting a diagnostic handle on what's going on, but you have potentially cells available for future research. And this is quite important, especially if you have serial specimens from any given individual, because it allows you to not only know what happened at a certain time, but also across time as patients have received treatment. Can I have the next slide, please, Zach? So this, I don't want to dwell on this too much, but how we make the diagnosis and how we can work up assays for quantifying minimal residual disease is based on our understanding of how lymphocytes normally develop. So this is just the example of how B cells normally develop, but they normally develop in a very ordered way. And as they go from being a stem cell to a mature B cell, which is a cell which normally produces antibody and helps to defend you in that way, they undergo certain changes. So listed here are things that are expressed on the cell surface during lymphocyte development. And those antigens continue to generally be expressed on ALL cells, but they're often expressed in abnormal and asynchronous ways that's not the same as would happen when a normal lymphocyte develops. And taking advantage of looking at the cell surface expression, it enables us to tell something about the ALL cell and to be identifying it in particular. And the other thing which is important is, as in the normal situation, the B cell is going to be producing an antibody. Each B cell produces one antibody. So each B cell essentially is very specific for whatever antigen it ends up making antibodies to. And in order to do that, the B cell has to undergo a lot of clever things. So it's rearranging all the different genes that comprise the genes that are eventually going to put the antibody together. And that knowledge helps us to develop assays for minimal residual disease. So the way that minimal residual disease tests are mostly done in Europe is by developing a patient-specific assay. So for each individual, you identify exactly what their leukemia cells are up to in terms of how it's developing the genes and putting them together as if they were going to start making antibodies. And each assay is completely unique. So when we do minimal residual disease in ALL, it's normally a patient-specific assay that's been developed and that would only work for that patient. And it's quite an intensive thing to do, but it gives us a lot of additional information during the course of treatment, as I will explain to you. Could I have the next slide, please, Zach? Thank you. So as I'm sure you're all aware, ALL is a very age-related disorder, and it's quite interesting and distinct from other hematological malignancies, which tend to be diseases of older individuals. And as you can see here, this is from data from the United States SEER registry, so that's just their baseline cancer registry, there's a first peak in the incidence of ALL around the age of 10. And then thereafter, the incidence sort of decreases. So the smallest number of people contracting ALL are older teenagers and younger adults. And then thereafter, the incidence rises slowly with age. And so it looks, and we do know from quite a lot of previous work in childhood ALL, that many children with ALL develop some of the genetic abnormalities that they're going to get, which are the precursor to having ALL. They actually arise in utero. So many children are born, you know, with the propensity to develop ALL, and there you see the peak of it. But it's extremely unlikely that what happens to you in the sort of in your 60s, 70s, and 80s depends on something that happened in utero. So it's probable that what causes ALL in childhood is probably not the same thing that causes ALL in adulthood. And indeed, although they have the same clinical manifestations, they're probably two different diseases in certain ways. But we don't know quite enough about that yet. But I think that's going to be a most important thing to look at, because most of the therapy that we use for adults, ALL, was originally modeled on how children were treated. And that's had some successes, but it's also, you know, led to the treatment being extremely toxic, because something that can be tolerated by a 10-year-old is very difficult sometimes if you're 50 or 60. Could I have the next slide, please? So how do we figure out who is going to have a good or a less good outcome? So what we do our very best to do for each individual patient is try and develop some idea of what the prognosis will be and what the risk for that patient might be, so that we can try and work with the patient to figure out what type of risk we might want to take in terms of treatment. And so we use essentially biomarkers. So what's important is that a biomarker is some kind of biological marker which is present in tissue or blood or other fluids. So and there are two types of biomarkers, and this is quite important because they're often confused with each other. So prognostic biomarkers correlate with the natural progression or aggressiveness of a disease. So for example, if you have certain genetic abnormalities in AML, for example, a 411 chromosomal translocation, we know that that would naturally make your disease more aggressive than if you didn't have that. But predictive biomarkers are very different. So they're defined by their role in predicting response to a given situation. So when we quantify minimal residual disease, for example, in any given patient, that's a predictive biomarker, because minimal residual disease takes into account a lot of other things rather than, so predictive and prognostic are quite different. And predictive can be much more helpful at times because they take into account a lot of things, as I'm going to show you. So Zach, could I have the next slide, please? So these are just a few examples of the different types of prognostic and predictive biomarkers that we use in ALL to try and tailor our treatment to be appropriate for the patient. So as I've already mentioned to you, age is quite important. So there is a worse outcome with advancing age, but there's no clear cutoff. So it's not like if you're 40, you're going to have a different outcome in particular than if you're 41. Although in clinical trials, we have to set ages because that's part of how we do that type of research. In many cases, defining how we treat people by age is not a good idea, because age is not really it's a thing, but it's not a biological thing per se. So, but it is important to take into consideration. Generally, if patients have high presenting white cell counts, that can have a worse prognosis. We know that certain cell surface expression of certain markers like CD20 can be associated with a less good outcome. We know that certain abnormalities that you find in cytogenetics, very similar to, pardon me, and certain molecular abnormalities, very similar to how it works in AML, can also have a lot to say about what might happen. But predictive biomarkers are a little bit different because they can actually tell you, despite all of the prognostic biomarkers, how a patient is actually responding to treatment. So, for example, whether you have a good response to steroids when you first start to taking them, the speed of your initial response, and absolutely critical is this one, minimal residual disease. So there's an extremely clear relationship between minimal residual disease at certain time points and outcome. And it can definitely be one of the most important factors leading to how we try to change and guide treatment. Could I have the next slide, please? So as you're probably well aware, there are absolutely tons of different genetic subgroups of ALL. And this slide here just sort of tries to represent some of that for you. So what's important to take away from this slide is that there's a different pattern in children versus adults. So you don't really see a ton of the detail, but if you just look the way the colours are split up, you can see it's coloured completely different. So some abnormalities, which are very common in children, for example, hyperdiploidy or 1221 translocations, they comprise up to half of all children, whereas in adults, those abnormalities are actually quite rare. So it's another indication that we're dealing with you know, an overlapping syndrome, but essentially some kind of big difference between younger people and older people. Can I have the next slide, please, Zach? So what are the principles of treating ALL, and how do we go about simplifying that, some of that complexity into how we treat an individual? So often individuals with ALL may need immediate treatment because they might be unwell and they might have presented with infections. But sometimes people aren't particularly unwell. You know, we just made the diagnosis, but they're otherwise okay, and they don't need to start treatment the next day. But by and large, we would think of ALL as an emergency, and we would not wait before trying to get people involved in treatment. And treatment essentially is divided into supportive management. So all the general things we have to do to keep people well, to try and prevent them getting infections, to make sure they're well hydrated, you know, to preserve their organ function and so forth. They can be started straight away. And so that's what we often do, is we immediately initiate the supportive care and do our best, if there are options, to try and consider the patient's preferences. So one of the big things that we do in the United Kingdom is to make sure that younger individuals have access to specialised units that look after patients who are teenagers and young adults. So obviously children are managed in paediatric units, but teenagers and young adults have the right to be referred to a specific teenage and young adult unit, which caters specifically for people of that age, which suffer very particular problems. And when you have very older individuals, so people who might perhaps be in their 80s or 90s, it's important to have conversations with those individuals about what they really want out of their treatment, and make sure that you try and consider all those preferences before you really start any therapy. And at the same time, we have to ensure that we've done all the correct diagnostic investigations that will tell us a lot of the information that I've previously demonstrated to you about prognosis. But there are certain things we very specifically need to do. So in adults with ALL, I'm sure you're aware that approximately 25 to 30% will have the so-called Philadelphia chromosome, or the translocation between BCR and ABL, which is essentially a bit of chromosomes 9 and 22 breaking off and sticking to each other in an incorrect way, which generates a very specific subset of ALL that requires specific treatment, because we already have a targeted treatment that can work for such patients. There are also things that we need to do to try and analyze certain genetic variants that might put people at more risk of certain drugs. So this here, thiopurine methyltransferase, is an enzyme that affects how people metabolize 6-mercaptopurine, which is a very commonly used drug in ALL. And so we try to figure that out at diagnosis, because it allows us to tailor the dose to be appropriate for the patient. If patients, we suspect they might have disease outside of the bone marrow, we might want to do some imaging to find out where that is, would be the liver or the spleen or the lymph nodes. And sometimes in ALL, people can have disease that's in the central nervous system. And if we suspect that, we would do a lumbar puncture at diagnosis. And we'll talk a bit more about why we need to think about the central nervous system subsequently. It's also vital to take a specimen for minimal residual disease at diagnosis because, as I explained to you earlier, it's a patient-specific test, and it needs to be done on diagnostic material from the patient's ALL. So even though we're not going to be looking at minimal residual disease at the beginning because the person has maximal disease, it's still vital to take that specimen. So we need to be certain that's done. And the other thing we always try to do at diagnosis, which can be, I think, very difficult for patients and their families, is we always try and tissue type patients and their siblings at diagnosis, even if it's not at all clear whether an allogeneic bone marrow transplant will be needed, because it can take some time to get the tissue typing results back. And it's absolutely critical that, that we allow the time for that to happen. But I think that's a point of tension, and it's very upsetting, I think, for people, because it takes ages from when you have tissue typing done to get the results back. And usually the results are given back to the actual siblings as opposed to the patient themselves. So it can be a tense time because everybody wants to think they have a donor. And it usually takes a few weeks to work that out. And even so, we might not be using an allogeneic bone marrow transplant. It's important that we know whether we have a donor. And then we would normally start a steroid pre-phase. So that's quite a helpful time for patients because steroids are very important in the treatment of ALL, and although they have quite a lot of side effects, they can sometimes make people feel a lot better very quickly. So if you've been feeling really grotty and you start to take some dexamethasone or prednisolone, whatever the steroid is, often your white cell count will come down very quickly and patients will feel a lot more energy. Often it will improve the appetite, and so sometimes people can feel quite good on steroids, and it gives some time. Normally the steroids are given for 5 to 7 days, and it allows some time to discuss some of the more complex things that we have to do to talk about fertility preservation, get some of the investigations that we need back, and help us to give a little bit of time chatting to the patient and understanding more about their needs before we start chemotherapy, which, as you know, at the present is still the mainstay of de novo treatment for ALL. Although targeted therapies are becoming increasingly important and they're vital in Philadelphia positive ALL. Could I have the next slides, please? So what are the principles of chemotherapy and how do we sort of look at it in an overview? So essentially what we're aiming to do is that the therapies are all called stupid names, and really they could be called course 1, course 2 and course 3, but we're kind of stuck with the historical names that they've been given. So the first course of treatment is generally known as induction, and the aim of induction is really to obliterate all immediate evidence of the leukemia and to obtain something called complete remission. And in the olden days, complete remission was our only way of knowing how patients had responded to treatment. And what it really means is that when you take a patient's bone marrow and you smear it out on a slide, just like I showed you in one of my previous pictures, and you look at it down the microscope with the eye, with the human eye, then you see less than 5% blasts. And so it's not a very scientific term. And these days it's probably really being superseded by more sophisticated testing, in addition, especially minimal residual disease testing. But it continues to be an endpoint that's often adopted as critical within clinical trials. And it's an endpoint that patients are very concerned about because we say we're hoping to get you into remission. And remission really just means the state you're in on the day. And it doesn't necessarily mean anything about what will happen to you in the future. But if you don't achieve remission, it does mean something. So it means that at the beginning, your disease is relatively resistant to treatment. And in ALL, that's actually quite uncommon. So the vast majority of individuals, even older individuals, approximately 90 to 95% would be expected to achieve remission after induction. So that's an important component of therapy. And when a patient's in remission, there is value to that because all of the normal cells will normally come back into your blood, and it puts you in a much safer situation because you've got normal neutrophils and you're normally then able to not be so at risk, and it puts you into a situation where you're no longer at great danger. So it's important to achieve complete remission from that point of view, but in terms of what it means for your future with ALL, then it's more difficult to say what that means. We also very much care about protecting the central nervous system of our patients. We know for certain that if we don't give intrathecals and drugs which cross the so-called blood-brain barrier and get into the fluids surrounding the brain and spinal cord, there is a risk of ALL cells lodging there. And we put a lot of effort in protocols internationally to try and prevent that. So unfortunately for patients, they do need to receive intrathecal treatments, and that can be a bit scary for patients. And then at a certain point in the protocol, we'll take what we've got and do some kind of assessment to find out what the risk is for that patient, taking into account all the prognostic elements that we mentioned earlier, and minimal residual disease. So minimal residual disease probably supersedes certain things. So if you present with a very high white cell count, which wouldn't be a good thing, but you nonetheless have a great response to treatment and you end up MRD negative, that probably overcomes that risk. But if you've got high risk cytogenetics and you become MRD negative, that might not completely overcome that element of risk. So we're thinking all the time about how to balance the different risks conferred by the observations that we have. These days, we are allowed to use the agent blinatumomab, which I will speak to you about in a moment. And of course, we have to make critical decisions about whether patients will go on for a bone marrow transplant or continue with chemotherapy that we then end up calling intensification, consolidation, and maintenance. Can I have the next slide, please? And so all of these things determine what will go into the initial treatment response. So both the treatment we deliver in terms of the actual drugs, the scheduling, sort of interactions between the drugs, things we know about the properties of the leukemic cell, how much leukemia there was, what the genetic lesions are, obviously the properties of the individual who's the host for that leukemia, so their age, the other illnesses that they might have, and how their individual physiology tackles metabolizing the drugs. And that can be extremely different between different patients. And we also know that the environment in the bone marrow, because the bone marrow isn't just comprised of leukemia, it's comprised of structure and other cells. And we're beginning to know that some of those other cells in the patient's bone marrow can actually kind of hold hands with the leukemia cells and affect how the leukemia cells are. And all of these things combine to give the patient a response, but also potentially to give toxicity. So how harsh the treatment is and what impact it might have on individuals is also very varied. Can I have the next slide, please? And so minimal residual disease helps us to refine that. So this curves help you to understand, I hope, what minimal residual disease can add for us that we can't see under the microscope. So on this side here, these are the sort of number of leukemic cells that you might have in going down. So this would be like 100%, and then, you know, 1 in 100, 1 in 10, 1 in 100, 1 in 1,000, 1 in 10,000, etc., etc. So an individual patient could have a good response to treatment, but the detection under the eye from a person looking down the microscope is probably about 1 in 10 to about 1 in 100. So somewhere here, you would say that all these patients were in remission, and yet below the surface of the iceberg, there can be a variable amount of disease still remaining in the patient's body, and helping us to really assess that is minimal residual disease, and that's absolutely critical. Can I have the next slide, please? And so how do we choose among the different treatments for an individual outside a trial? So in my experience, because I'm academic and I'm really into clinical trials, I would strongly encourage my patients to enter clinical trials if they're willing to. But if nobody's willing to enter into a clinical trial, we're essentially taking a number of things into account in deciding treatment. Obviously, the age of the patient is critical. It does make a big difference whether you're 10 or 80 years of age. If you have other illnesses which will affect the tolerance of treatment, Obviously, depending on what country you're in, different therapies may be licensed or reimbursed. And it's absolutely critical to take into account what patients want if there is a choice. Sometimes your back can be against the wall and you feel like there's no choice, and that's a difficult situation to be in. So I usually do my best to emphasize what choices there are, because nobody wants to feel that they don't have any choice. Zach, can I have the next slide, please? In our study in the UK, we had the following features of high risk disease. So we had high presenting white cell counts, older age, the following cytogenetic abnormalities, and we used MRD as also as a risk factor. But different trials in different countries will take different features, but by and large, these are the critical features that most would assume would make a patient having high risk ALL. Can I have the next slide, please? And I'm not going to rehearse this. I'm happy to discuss it in great detail if anyone has a question, but how to decide whether somebody has a bone marrow transplant or not is a massively thorny and difficult question. But the bottom line is, if your risk of relapse is greater than your risk of suffering harm from the transplant, that's when we will propose you have a transplant. And how to do that, hopefully we use all of the other types of information that I've decided on, but this is something we have to discuss a lot with an individual patient. So if anybody would like to discuss this with me more, I will happily just take questions on it, but I'm not going to dig into more detail here because it's a really difficult topic. Could I have the next slide, please? So I'm just going to spend the last couple of minutes talking about some novel therapies, because I think these are already beginning to impact the way that people are treated in an extremely positive way. So I'm sure you're all aware that immunotherapy is particularly important in ALL. And bone marrow transplant is essentially a very strong immunotherapy, but it's a very toxic one. Unfortunately, we're getting some newer therapies which allow an immune effect without having so much toxicity. So the most critical one that's emerged in the past 5 to 10 years is blinatumomab, which is a very interesting drug. So at the time of approval, it was a first in class, so there had been no previous drugs that worked like this. So it's an antibody, but it has two ends to it. One that sticks to what's called CD19, that's on the surface of the leukemia cell, and then the other end sticks to CD3, which is on the surface of normal T cells. And what this drug essentially does is pull the leukemia cells physically next to normal T cells and help to deliver a signal to tell the T cell to kill the leukemia cell. So we know that in patients who develop cancer, there has been some kind of failure of their own immune system, in some sense, to let the cancer develop. And what this drug does, it kind of re-educates your immune system by dragging it, kicking and screaming next to the leukemia cell. And as long as there are the drug present and you have T cells, then generally this drug can be quite effective. It's much more effective if given in a situation of minimal residual disease. It's been tested now in both relapsed ALL and found to be superior to chemotherapy. And it's also been tested in situations of minimal residual disease. And it's given, as some people may have experienced it, by continuous intravenous infusion. But, and I caught the end of the previous talk, oftentimes patients don't need to be in hospital. So it's, although there are toxicities reported, way less toxic than chemotherapy, and gives a much better experience. And if appropriately used, it's probably going to change. It's a game changer in ALL, and there are now increasing studies trying to work out how we can use that more in de novo disease. Next slide, please. We have inotuzumab, which isn't really an immunotherapy, but it binds to something on the surface of leukemia cells and delivers a toxin, and again is now available for patients with relapsed disease. It can be extremely effective in eliminating disease, although responses don't tend to last too long, so you will definitely need a therapy after that, often bone marrow transplant, but again, way less toxic than standard chemotherapy, often given without it hospitalization. So really potentially a very big advance in the experience that patients will have. And I think my hopefully my last slide is on chimeric antigen receptor T cells. And I can see that there's going to be some questions on CAR T cells, so I'm not going to rehearse this too much, but essentially these are very exciting potential therapies also in immunotherapy that relies on taking T cells, usually out of the body of the patient themselves, and then engineering those T cells by changing their receptor using a gene therapy technique to modify the T cells so that they will recognize the cancer and kill it. And then essentially you put the T cells back into the patient. And CAR T cells have now been principally tested widely in young individuals, but are becoming more widely tested in adults. And I think there are some questions about CAR T cells, so I'm happy to take those questions. I won't say any more now. And my next slide, please. Just what I do want everyone to know is that certainly in the UK, and I know across the majority of developed countries, there are enormous efforts by study groups who do work together actually, but you know, to collect massive amounts of data. So not just putting patients into clinical trials to collect clinical data, but to collect a lot of data and do a lot of research using the specimens to try and develop new ways of looking at ALL and new ways of treating ALL. So I want to reassure people that if they've participated in clinical trials, they've probably already participated in their specimens being, you know, involved in this sort of work, which is really going to take us further forward. And the next slide, I think, is the last. Just move us on. Yeah, so I just want to thank everybody from my group who's been involved in our UCAL 14 trial, and now I am happy to take questions. So I see that there are some questions already in here, so would you like me to go through those, Zach?
I'll run through them for you, Adele,
Okay,
so
brilliant,
that's
thank
fine. So obviously the last ones we had through around CAR T therapy, but probably let's start there. Could you explain to us a little bit about why in ALL CAR T therapy is only being used in younger patients up to 25?
Yes, I can explain that, and I think it's a sad situation actually. So the reason that's been done is because that was the age of the patients who were involved in the trials. So essentially when CAR T were first developed, they were initially tested on children with relapsed ALL. And the major trial on which CAR T was approved for ALL was the Eliana trial, which was carried out principally in the United States. And the age of the patients in that trial was a certain age. And when you come to approve a drug, you essentially have to base your approval on the data that comes from the trial. And the indication for the drug has to be the indication that was tested in the trial. So that's the entire reason why we have those age limits, and it's most unfortunate actually because it's most unfortunate for a lot of reasons, and I think part of the problem is that as people probably know, CAR T cells are really expensive. So if you get the Novartis CAR T cell product, which is the one that's approved in the UK for young people, I think it's about £500,000, and I am a bit cynical about why that was approved for a certain age group on the basis of a single arm study, because the Eliana trial that was based on the approval was a single arm and not a randomized study. And the regulatory authorities are essentially saying they probably would want a randomized study in order to extend approval to older individuals. And there was going to be one. Novartis had actually planned to do a randomized study, and now they have decided not to do that. So I'm not entirely sure why. So it's an awkward situation and not ideal.
Thank you. And another question in relation to CAR T. Where do you see the future role of CAR T therapy going in ALL, and particularly around potential for off-the-shelf CAR T therapies? What role do you think they'll play?
So the off-the-shelf CAR T cell therapies are potentially quite interesting because they're CAR T cell therapies that are developed from allogeneic donors. and they've had things done to them so that the allogeneic or T cells from another person wouldn't react against the person they're infused into and give graft versus host disease. So there are some ongoing early phase trial with off-the-shelf CAR T. I'm not aware. A lot of the trials actually are being done in China, so we mustn't downplay what's come out of China. There's some off-the-shelf CAR T cells being done in Europe as well, and I haven't seen a lot of that data published, so I'm not sure how it's going to be compared to autologous T cells, but it would certainly make life a lot easier for patients, because one of the problems with CAR T, and also the problem with the way the data are reported, is there are quite a lot of people who would aim to get CAR T who will never get it. So patients in whom you can't harvest T cells, patients in whom you can't make a product, and patients in whom, you know, unfortunately their disease progresses before they can get the CAR T. But when you look at the data coming out of CAR T cell studies, it's normally analysed by who received the CAR T cell and not by what we call intention to treat. And that makes it very difficult to see where CAR T cell might go. Because if you are thinking about how we currently use CAR T cell, somebody will have relapsed ALL, and we use all of the elements that we have at our disposal to try and keep their disease at bay until they can get the CAR T. And it takes a number of weeks to prepare the CAR T product. And so it's an extremely fraught time. And without the novel agents like blinatumomab and inotuzumab, a lot of patients wouldn't even get to CAR T. So it's quite difficult to, with all of that, to envisage how it's going to fit in up front. Because we also know that the more disease you have on board, the more likely you are to get these severe side effects of CAR T, and a very significant number of patients will end up in ITU. And we certainly don't know for older individuals whether some of those situations are survivable. So there's a lot of work to be done to figure out the role of CAR T, because they are effective but not applicable to everybody, but also extremely toxic. And I think we do need randomized trials personally, but it's going to be very difficult to do them. And I think that's partly, I was involved a little bit in on the steering committee of the Novartis trial that they pulled. And I thought it was a really brave trial, because it would have answered quite a lot of the questions that we have, and now it's not going to happen. So I think it's going to be tricky because the therapies are so expensive. And I feel a bit cynical why they were only approved for young people, but there we go. What else would you like to ask?
So a related question, and you kind of touched on it a little bit during your presentation, the role of transplant in terms of determining who transplant is either needed for or appropriate for. How do we do that at the moment?
Well, I mean, that's why I try and, if possible, to encourage people to go into trials. I think the clinical trial, and there is a question on there about why do you offer patient a clinical trial as the first option. I think that because ALL is a rare disease, one of the most important things is to try and collect information. So clinical trials don't always involve like testing scary new therapies in people. So when we would offer a patient a clinical trial as a first option, it generally would only be a phase 3 trial where we are offering everybody standard of care. And on top of standard of care, some patients may be offered a randomization to something that might add something to standard of care. So if you're offering someone a trial at diagnosis, you really are only offering what's already best therapy. So you would never offer a trial that had something that wasn't best therapy. So you'd use best available therapy and add something on top of it. And we always have to think in clinical trials about how the hell we're going to analyze the outcome of bone marrow transplant, because we know that certain people will definitely benefit from bone marrow transplant, but it's very difficult to test that in trials because you can't randomize people to whether they will have a bone marrow transplant or not, because there's just no equipoise, and you can't ask an individual to toss a coin on a bone marrow transplant. I think you're okay to ask individuals to toss a coin on drug A versus drug B, but a bone marrow transplant is so very different from not having a bone marrow transplant that there's never been a satisfactory trial where transplant's been randomized. So all our knowledge that we have from transplant is really based on single arm studies. And it means that our knowledge is somewhat incomplete and unsatisfactory, despite the fact that we've been using these therapies for 20, 30, even 40 years. And deciding who should have it is still to some extent unsatisfactory. And what we will try and do is, that unfortunately there's an inherent treatment-related mortality to bone marrow transplant. So, approximately 15 to 20% of people who will undergo bone marrow transplant will somehow die as a result of having that transplant. But if your risk of dying from leukemia is 80 to 90%, then it's worth taking that risk. So what we're really trying to do is balance the scales, and at the same time talk to individuals about how they feel about having those scales balanced, because some people are very keen to have a bone marrow transplant and some people really don't want to have it. So I think it's tricky, and it needs to be done on an individual patient basis, and it still is, in every unit, whether people are in a trial or not. You end up having these conversations with people, and you have to really, it's hours and hours worth of conversation, and you can't really predict someone's future. That's the problem. You can use statistics to predict the future of a group of individuals, but for any given individual, you can't say if we do A, then B will happen. You say if we do A, then B to Z will happen. And with bone marrow transplant, any outcome is possible, and you can't tie that to what might happen for a person. So I think it's one of the most difficult areas of practice.
Thank you. So a really interesting question and topical at the moment. What impact has COVID had on ALL treatment in terms of, is anyone having their treatment delayed, transplants delayed, for example?
I can't speak that there has been quite a good paper that was published by the Italian group, because they managed to sort of summarize their entire experience. If anybody wants to look at it, I think it was in Lancet Oncology. In general, what we've taken the approach in the UK is that people are more likely to die of ALL than they are of COVID. So we haven't made any adjustments to how we treat our patients, because we think that they need to be treated. And we have just carried on treating people as normal and just being really careful. So in my hospital, for example, the initial thing was to get all the COVID patients into one place and all the non-COVID patients into another place. And now we've managed to get it so that everyone who comes through the door is COVID screened, before they start. And if they come back as an outpatient for any procedure, they have to have COVID screening before they come in the door. So we've managed to keep our cancer treatment centre a COVID-free unit. At the beginning, we did see patients who were co-infected with COVID and had ALL at the same time. And so we saw quite a few newly diagnosed patients who had both. And I think generally what happened was those patients were diagnosed a little bit later, because some of the symptoms they were having from their ALL were attributed to COVID. And when they would call, the NHS, they were told to stay at home and sit it out. So I had quite a few patients present probably a couple of weeks later than they might have done, because they assumed they had COVID. And it was only when they didn't recover from what they thought they were having that they eventually ended up at the hospital. And I had a few people who presented with both, and they actually all did okay. So it's quite interesting, because obviously, you would feel that if you had newly diagnosed ALL and COVID at the same time, it would be certain death. And actually, I had older patients that were diabetic and had COVID and ALL, and they were fine. So it's a real mixture. But we did keep everything going, and we didn't actually stop doing any of our treatments. And I think I might be different in different places.
Thank you very much. So a question around minimal residual disease, which you touched on. Do you see that playing an increasing role in ALL treatment and monitoring going forward?
Yeah, it already has a really huge role, but I think where it's even more important now is because we have blinatumomab approved for use in patients whose disease remains MRD positive. And so we finally have a therapy where MRD is directing that therapy. What we used to do is, you know, you're MRD positive, and so that's higher risk, so you're probably going to have a bone marrow transplant, but we weren't certain, especially if you're having reduced intensity conditioning, that would overcome the risk. But there's some really great data for MRD responses in patients who receive blinatumomab, and it's a perfect setting to administer immunotherapy. So to the person who was asking earlier on about the role of CAR-T, I think if we get to the stage where we are allowed to use CAR-T cell in minimal residual disease, that will be a good situation. So if we have patients that we know their risk from having MRD, that their relapse risk is quite high, but you're allowed to give an immunotherapy at that point, you're going to get the best outcome because you've got the less disease for the immune system to work on. You're probably also going to get less toxicities. So I think MRD is going to be really critical as well in determining in the future who might have CAR-T, because once we've worked out who should get CAR-T when they relapse, the next job will be to work out who should get CAR-T at the beginning. And it's a complex job to work it out because of the toxicities, but I think MRD is going to be absolutely central to doing that.
And then one last question, because we're already over time. So with patients, particularly pediatric patients receiving quite intensive treatment, what is the likelihood of them having a kind of second malignancy, such as an MDS, later on in life?
I don't think it's that high, but there's always a risk. I mean, and it's so cruel, you know, secondary malignancies. The risk is not lifelong, so the risk of getting a second malignancy is probably, I think, about 2 to 10 years after therapy, and then you know the risk goes down again. So it doesn't increase with your increasing life. So it's not like if you had therapy for ALL as a kid, your risk of getting therapy-related MDS carries on getting worse all your life. It will likely, you know, stop at about 10. So you don't see it very much. I mean, I can't tell you the precise data from UCAL14 because we haven't analysed it yet, but it's probably a relatively small risk. It's less, I think it's less than 1%. But it's cruel when it happens, very cruel. You know, I've seen it happen to one patient of mine, and it's just heartbreaking, you know, that you've been probably cured of one type of leukemia, and then the next minute you have another one. You know, it's a really awful thing to happen. And, you know, the sooner we move away from the types of chemotherapy that put you at that risk, the better, in my opinion, you know, and I think in the next 10 years, we might be able to do that. You know, we're starting to move away from using some of the more toxic treatment, but unfortunately it's still the mainstay of treatment.